Good morning, and welcome to this webinar on Iron Deficiency Awareness Day. This is a webinar co-organized by the World Heart Federation together with the European Hematology Association and sponsored by V4 Pharma, which I take the opportunity to thank for sponsoring this program. Iron deficiency is present in about 1/3 of the world's population. But in certain groups of patients, in particular patients with heart failure, there is a high proportion of these patients who are affected by this condition. This webinar will explore the link between iron deficiency and heart failure, and will identify some strategies to improve awareness and prevalence of iron deficiency in people living with heart failure. We have the chance today to have three outstanding panelists that will help us in this discussion. Myself, my name is Fausto Pinto. I'm based in Lisbon, Portugal, where I'm the Dean of the Medical School and head of the Cardiovascular Department at the University Hospital of the Academic Medical Center of Lisbon. And I'm also the President-elect of the World Heart Federation. We have today with us Professor Ali Taher, who is a professor of medicine at the American University of Beirut Medical Center, is a renowned researcher and expert in hematology, and he will give us a presentation on iron deficiency in just a few seconds. We also have Mrs. Aiste Staraite, who is the president of a patient association in Lithuania, the Lithuanian Heart Failure Association, which is a member of the Global Heart Hub. And then we have Professor Antonio Almeida, who is a hematologist. He's the head of department at the Hospital de Luz in Lisbon, Portugal, and he's also a board member of the European Hematology Association. So I really hope that we will have a chance for the next hour to discuss some relevant topics on iron deficiency and how can we improve the way we deal with this condition, increase the awareness of this condition so we can improve the lives of our patients and our communities. So I will invite now, and we will have now a short video from the World Heart Federation that will show in a very short way what is iron deficiency awareness, and I invite you to watch this video.
Iron is essential for keeping our bodies and brains healthy. It brings oxygen to our blood cells, helps convert food into energy, and enables us to maintain a normal immune system. Too little or too much iron has detrimental effects on the body and can lead to arrhythmia and blood pressure anomalies. Anemia is a decrease in the total amount of red blood cells, or hemoglobin in the blood, leading to a lowered capacity of the blood to carry oxygen. The most common type of anemia is caused by lack of iron, such as in blood loss or extra need of iron, as in pregnancy. Iron deficiency without anemia can occur when a person has a normal amount of red blood cells, or hemoglobin, but below normal iron in the blood, which is measured by serum ferritin, protein that stores and releases iron, and transferrin saturation that are too low. Anemia and iron deficiency are two important comorbidities in heart failure. Up to 50% of patients with heart failure are iron deficient. The consequences of iron deficiency in heart failure include reduced functional capacity, increased risk of hospitalization, increased symptoms, and poorer quality of life. The European Society of Cardiology Heart Failure guidelines recommend iron deficiency testing in newly diagnosed heart failure patients. Intravenous iron is the recommended treatment to alleviate heart failure symptoms and improve exercise capacity and quality of life. There is no clinical evidence of oral iron benefit in heart failure patients.
So again, back to our webinar. We'll have the chance now to listen to a short presentation by Professor Ali Taher. And you will have the chance to ask any questions you'd like through our chat. And then at the end, we will have some time for discussion. So it's my time now to give the floor to Professor Ali Taher. As I mentioned, he's a well-recognized expert in the field of hematology. He's a professor of medicine at the American University of Beirut Medical Center. So Ali, please, the floor is yours.
Thank you, Professor Pinto, for the introduction. I'm very happy to be with you on the Iron Deficiency Day and with this prestigious group. So today, as you know, 26th of November is the Iron Deficiency Day, and the hashtag of today is to take iron seriously. The aim of this year's Iron Deficiency Day is to highlight global impact of iron deficiency on health and gender inequality. Although it's not really related to the heart failure, but I like to start my presentation by this. Now, as you know, the video was very good. It has explained everything. So I'll try to highlight all these points in a very short presentation. As you know, the prevalence, more than 60% of anemia is caused by iron deficiency, whether in males or in females. And if we look at the 1990s and even in the 2000s, still iron deficiency and iron deficiency anemia is a major problem worldwide. Some quick facts: it affects up to 1/3 of the world's population, and this is really a very large number. And iron deficiency is the most common nutrient deficiency worldwide. Around 4 to 5 billion people may suffer from iron deficiency. And the World Health Organization states that iron deficiency can lead to a reduction of 30% in physical work output, which is really very important worldwide. As you have seen in the video, iron is important because iron is present in hemoglobin, and it is important to carry oxygen into all our tissues. So without iron, patients will have a lot of signs and symptoms, whether related to iron deficiency or to iron deficiency anemia. So very briefly, iron deficiency, if you want to define it, is a very common but often overlooked, especially in people with chronic conditions like heart failure that we will be highlighting today. It's a health-related condition in which iron availability is insufficient to meet the need of an individual. So you've heard that we talk about iron deficiency and iron deficiency anemia, and this is very important concept to differentiate that not any iron deficient individual will have iron deficiency anemia. So in these figures, if you look at the blue part, which is the iron, and the red part, which is the hemoglobin, you would notice that sometimes the blue is little, which leads to iron deficiency without reduction in the hemoglobin level. But if the iron decreases a lot, then the individual will have iron deficiency anemia. So iron deficiency is not the same as iron deficiency anemia, and both are important conditions that need to be treated. Iron deficiency, as I said, can occur without iron deficiency anemia, and iron matters a lot, not only in a healthy individual, but it matters a lot and more in patients that suffers from chronic diseases such as kidney failure, such as irritable bowel disease or Crohn's disease, and most importantly, such as chronic heart failure. It's associated with a lot of clinical deterioration and lead to poor outcomes, including prolonged hospitalization and a poor quality of life. We have two types of iron deficiency, and this is very important to be understood by everyone, not only by physicians. The absolute iron deficiency, where the store of iron decreases. A very good example would be a woman who is menstruating or a man who is losing blood, so the store is decreased. And another group is the functional iron deficiency, where we have a good store, but the individual cannot use this store. So not every iron deficiency you will lose iron. It can be poor mobilization or use of iron. And these are two important concepts, because in heart failure, you have these two components of iron deficiency that are present. How can we measure iron deficiency? To all of you, ferritin is a very important marker that we always talk about in iron deficiency. However, in patients who have immobilization problem, we need to measure the saturation, because sometimes the ferritin might be high, yet the saturation might be low. And this is typical in patients with inflammation or with chronic diseases such as heart failure. For sure, hemoglobin to see if the patient has anemia or not. A good example on these inflammatory diseases is heart failure. The symptoms, I will not go through the details, but these patients will have a lot of symptoms, including fatigue, lots of signs, pulmonary crackers, peripheral edema, and this would lead to a poor quality of life. So if these symptoms are associated also with symptoms of anemia, you would see that this will be exaggerated a lot. Why should they have anemia? They should have anemia because of two reasons: the absolute loss of appetite, taking a lot of medication, losing blood, taking antiplatelet, and at the same time, they have a problem in mobilization, which is the functional iron deficiency because of the inflammatory process. So patients with heart failure have these two components. As you've heard, up to 50% of patients with chronic heart failure might have iron deficiency, leading to worsening the symptoms, increase the risk of hospitalization, and a very important component to reduce quality of life and increase the risk of death. This is why, and so you've seen that this will impact the exercise capacity and the outcome of heart failure with reduced the ejection fraction, and we can hear soon from the heart failure presentation. The diagnosis, as I said, we should look into the cause of anemia, measure the hemoglobin. The patient might not be anemic, measure serum ferritin, but the most important is to measure the saturation, which is the amount of mobilized iron that means if there is deficiency or not. And this is a very simple algorithm. For patients with heart failure, we measure the serum ferritin and the saturation, including the hemoglobin. If they are anemic, we should look for other causes of anemia. If it is only iron deficiency, then these patients, as you have seen in the film, should receive IV iron. And all of the studies have shown the importance of IV iron in intravenous, iron in patients with heart failure compared to patients with other diseases. If the patient is normal, it doesn't mean that we should forget about it, and the cardiologist or the internist should repeat measuring the saturation and the hemoglobin of these patients. We have two types of iron: the oral, which is, I'll not discuss today, but a lot of people, especially people with chronic inflammatory disease, cannot respond to the oral iron because they don't absorb it because of compliance issue and some severe gastrointestinal GI problems. As a result, we have the IV iron, which have shown that it causes less side effects, can be absorbed very well, and all the studies on heart failure and the chronic inflammatory disease have shown the superiority of IV iron to alleviate the signs and symptoms of anemia if present, and to correct the iron deficiency in those individuals. I will not go through this diagnostic model, but this is a more exhaustive way of looking into this algorithm that I have presented and showing you that it is very important to correct iron, even if it is only iron deficiency, and do not lead the patient to become anemic, as the signs and symptoms of the heart failure will be exacerbated by this iron deficiency. So I hope I was clear in this presentation, showing you that iron deficiency is very common, and especially in heart failure, where 1 in 2 patients with heart failure will get iron deficiency. And you know, iron plays a very important role in regulation of the cardiac skeletal muscle function, so it's a necessity and importance to correct it. Iron deficiency is clinically, not only clinically, but prognostically important to be treated even in the absence of anemia. It has a negative impact, as I have discussed, on the symptoms and the quality of life, and on the exercise capacity and outcome of the patients. And the iron deficiency without anemia will result in progression of both impaired erythropoiesis, leading to anemia, and to exacerbate the heart failure status of our patients. Thank you very much to giving me the opportunity to summarize these information to you. Thank you.
Thank you very much, Ali. Professor Taher, was really exciting, this presentation that gave us a little bit of a perspective on the relevance and what it means to have iron deficiency on the different types. We will have a discussion at the end. And now we will move to Mrs. Aiste Staraite, which have, as I've mentioned at the introduction, she is the president of a patient association in Lithuania, the Lithuanian Heart Failure Association. And she will address actually a very important issue, which is her own experience. And I'm really grateful that you were able to join us, because it's very important and more relevant to have patient groups to share the experience of the ones who really have the experience of the disease, of all the issues related with the management of the disease. And it's becoming more and more relevant that, particularly for us physicians, for the scientific community, to have the involvement, the engagement of patient groups and patient associations, so we can improve the way that we can actually look at different conditions and be able to find better solutions. So I'm really grateful that you made the time to be with us today, sharing your experience, giving us your perspective. Also, give us a little bit the perspective, being a very relevant person involved in a patient association or patient group. Also, not only your own experience, but also if you could give us a little bit about the role of patient groups in the management of different conditions, and also to helping in a way to shape the way that we can improve patient management, and particularly focusing, of course, today on iron deficiency. So, Aiste, please, we're very much looking forward to listen to your experience and what you have to tell us. Please go ahead.
Thank you very much, Professor Pinto. Welcome, everyone. My name is Aiste Staraite, and I am from Lithuania. As Professor Pinto mentioned, I am a president of Lithuanian Heart Failure Association, and which is a member of Global Heart Hub. I am actually a patient myself. I've been diagnosed with end stage of heart failure 4 years ago. It was managed successfully for 2 years, but after 2 years, I had a worsening of heart failure, which led me to actually proceed for heart transplantation. And because it wasn't available, the heart transplant wasn't available at that moment, I was offered as a solution and bridge the transplant to move with the implantation of left ventricle assisting device, which actually helped me to live and come back to my normal life outside the hospital and wait for the heart transplant. So since implantation of left ventricle assisting device, I started experiencing the symptoms of iron deficiency, which at that time I didn't really know, and I had no knowledge about it, because obviously I know what everything is about the heart failure, but I wasn't aware of iron deficiency impact on heart failure. So from the first 6 months post-surgery, I could feel the dizziness, the fatigue, the heart palpitation, shortness of breath, and one of the most symptoms, the one symptom which actually caught my attention was the restless leg syndrome, which I didn't know at that time was the effect of the iron deficiency. So since obviously talking and being testing most of the time, every 3 months, when you stable after a left ventricle assisting device implantation, I had a conversation with my team, with my cardiac team, and we came to the solution to help me with IV iron to reduce the symptoms of the iron deficiency, which actually really helped, because with iron IV, you can feel the results within the couple of hours. And I think that's one of the best things for the patient, because you can feel better, you can feel more energetic, and you can just get admitted to the hospital for one day, get the IV, and just leave. But since now the situation with COVID, I was really experiencing some struggles in regards of getting the IV of iron. And I think the problem which we are now in terms of the pandemic and experiencing the second wave here in Lithuania, it is very complicated to get the treatment. So right now, what helps me is the oral usage of the iron supplements, if I can say that. And what I would like to inform everyone that, you know, the symptoms that we have and the symptoms that we feel in terms of like shortness of breath, heart palpitations, weakness, dizziness, we most of the time confuse those with heart failure, especially for the heart failure patients. And it's what I would like to say, that it is extremely important to communicate with your medical team and tell them how you feel, because it might not be the heart failure, it might be iron deficiency, which you actually need to improve and which you need to get the treatment for. So iron deficiency can really impact heart failure patients' life in a negative way. So it is very important to follow the testing of hemoglobin and ferritin quite closely. In terms of the association, as the association in Lithuania, we are collaborating heart failure patients and being a voice to not only the healthcare system, but the decision makers in the government. And what we are trying to do, we're trying to reach the better and greater results together. And that's what I would like to mention, that, you know, working together as the patient organizations, which are including the vast amount of heart failure patients, and not only heart failure patients, but the carers as well. It is important to work along together with organizations like Global Heart Hub or World Heart Federation. And because we do have the knowledge and we do have the experience which we can share, and it's really valuable to learn from each other. And in this time, and with the collaboration, we can reach the greater results for raising the awareness for iron deficiency, and of course the management of it. So that would be it from my side. Thank you very much again for listening to my story, and I will be waiting for the questions.
Well, thank you so much. That's really quite a fascinating experience, and we really appreciate you sharing with us your experience. We'll have a little bit more time later during this webinar to have a little bit more of your insights. But I will now move to Professor Antonio Almeida, who is also a clinical hematologist, and he will give his own considerations about the topic. So Antonio, please go ahead.
Thank you very much, Professor Pinto. First of all, I'd like to thank the World Heart Federation for inviting EHA and myself personally to this roundtable. I think this is a great initiative and very important to have cross-fertilization between different specialties, and above all, including patient associations. And I really applaud this and hope we have more of these meetings. Now, I was very impressed with Aiste's just talk, because I think she really highlighted the difficulties that many heart failure patients face. First of all, I think the main difficulty is that the symptoms of heart failure and of anemia and even iron deficiency can be quite similar. I was fascinated to see how well Aiste brought up the restless leg syndrome and other symptoms associated with iron deficiency in itself, and was able, in her experience, to separate these from the symptoms of heart failure alone. And I think this is a great difficulty which patients really need to be alerted to, is that there are different symptoms, but above all, that the same symptoms can be due to not just heart failure, but also due to iron deficiency and anemia. And this is something that needs to be brought to patients' attention. But above all, I think this is something that also needs to be brought to physicians' attention. I speak as a hematologist that very often we are referred patients with iron deficiency who have other conditions, and we perhaps are not as sensitized, shall I say, to the fact that we need to give them more adequate treatment, more adequate monitoring, and that they need to have regular tests and regular treatment at times. And Aiste was mentioning this, and perhaps it would be useful for you to just comment a little bit on how regularly you are monitoring. The recommendations say that that we should be monitoring at least once a year in heart failure patients for iron deficiency, that we should check it at diagnosis and then checking at least once a year. But in your experience, you clearly had a much more intensive monitorization with perhaps every 3 months and every 4 months. So, and I think that is quite an important aspect, is that this is a condition that needs a lot of attention and that needs a lot of regular monitoring. I think the other important aspect is the treatment. And I'm sure we'll be speaking about this soon, but Aiste did mention intravenous iron and how she went into a dialogue with her physician and decided that this was the best option. And I think there are two aspects here that I really want to bring out, is that treating chronic diseases is really a collaborative effort between patients and doctors. And I think that Aiste's witness of going to her doctor, telling her cardiologist that something wasn't right and that she needed more help with the iron deficiency, and coming up with a treatment plan together is something really that we all help each other in this path. It's not just a top-down attitude, but it's something that patients collaborate and participate in their own treatment. And secondly, actually going back to the evidence, and we all know that normally we give iron orally. Professor Taher, in his brilliant exposition, did show that we have 2 formulations of iron replacement. Most of the time we use oral iron, but in some conditions, oral iron is not adequate because it is not properly absorbed, because it is not well tolerated. And heart failure is one of these conditions. And in this sense, I think it is very important that both patients and doctors are aware of this and actually embark on these treatments that are more efficacious. But I just want to go back to my initial point. I think that actually looking out for symptoms, being aware of symptoms, and this in terms of being a patient is very much being aware of what you normally have, and if there are changes, that really alerts to iron deficiency and other things that can happen in heart failure. So patients really need to be looked at as a whole, not just as organ disease, but as a whole.
Well, thank you so much, Antonio. And we have now some time for discussion. We will have you will have the opportunity to ask some questions. Please do that. And we will try to accommodate your questions. Meanwhile, we can start our discussion with our panelists and addressing some of the issues that have already been raised, and maybe to get a little bit more into some detail in some of the raised questions. So shall I start with maybe Antonio again? Could you explain in simple way why iron deficiency is so prevalent in patients with congestive heart failure? Because that's really one of the issues that it's been more and more clear. And for many years, this was not really taken into account. But now it's clear that this is a particular group of patients that do have this issue of iron deficiency. So why is it so common in patients with heart failure?
Thank you. Now, I think that's a very important question. And I think there are lots of factors that contribute either in the same patient or in different patients. I think possibly one of the most important factors is low-grade bleeding. Many of the patients with heart failure are anticoagulated. This means that their blood is thinner, and having thinner blood does give a propensity to bleed. And in addition, many of the drugs that are given to heart failure patients, such as aspirin, etc., can cause a little bit of inflammation in the stomach and cause low-grade bleeding. The second main cause is difficulty in absorbing iron. Patients with heart failure accumulate a lot of liquid, and some of this liquid water accumulates in the wall of the intestine. And this means that the intestine wall is a little bit thicker, and iron absorption is an active process. And so if we have a thicker intestine wall, very often we don't absorb enough iron. And this means that this is also the reason why oral iron is not the optimal treatment in patients with heart failure. But then there are also other reasons, which is the chronic inflammation which heart failure produces. And when we have chronic inflammation, and this is not exclusive to heart failure, many chronic diseases have chronic inflammation. This produces some molecules which stop the body from using iron properly. It is one of the inflammatory responses. And so iron may even be there in some form, but the body has difficulty in including it in the tissues. And finally, very often patients with heart failure have problems with their kidneys. Now, this does mean that the kidneys are the organ that produces the hormone that stimulates production of red blood cells. Now, sometimes the kidneys are intact, but still the hormone is not working properly because of inflammation. But sometimes the kidneys do have a problem in heart failure patients, and not enough erythropoietin is produced. So increasingly, there's more knowledge that many factors are at play. And like you were saying, Fausto, this is a very important topic that for a long time was ignored. And now with increasing scientific knowledge and the importance of the prognostic and clinical effects of iron failure, iron deficiency, we are starting to pay more attention and to have better treatments for these patients.
Absolutely. That's a very good explanation. And again, it highlights the fact that it's really multifactorial, and we may have different mechanisms even within the same patient, but very important to have that attention to the individual patient. And that brings to another question, and maybe Ali would like to address that. You know, we've touched upon a little bit, but to be more precise, how frequently should patients with congestive heart failure be screened for iron deficiency or iron deficiency anemia? As you've shown a little bit, but would you like to detail a little bit more?
First, thank you. I just want to comment on Aiste a little bit that she's not only a patient with heart failure, but also she's a female, and her iron deficiency could be dual, which is really something very common. As a female having iron deficiency, which is losing blood, and at the same time from their congestive heart failure, as Antonio and I have explained in the beginning. So multifactorial causes of iron deficiency, not only from heart failure, but from other causes, is really very important. Now, how often we should check? It's very important. I mean, why did we had this misconception at the beginning? Most of the cardiologists and internists and even hematologists were checking serum ferritin only for these patients. And as an inflammatory disease, as I have started, as Antonio said, this is an inflammatory disease. So sometimes a serum ferritin would be 100 or 200 in these patients, yet they are iron deficient and not anemic. And this is why we have said in the guidelines that serum ferritin in chronic inflammatory disease is not enough and should be coupled with transferrin saturation, which is really very important in patients. And all the guidelines, especially the heart failure guidelines that came recently from the American Society or the European Society, stressed on this important. Now, if, as Antonio said, from the guidelines, it says to check every 1 year. However, each institution will have its own guidelines. What we have here is we have this clinic together with the heart failure specialist at the institution, and we have the iron deficiency anemia clinic for heart failure patients, where we are checking this every 3 months. the other important thing is once they take the IV iron, it is important to test them in 4 to 6 weeks to see if they need a booster, and then to repeat it in 3 months, because they might need 1 to 2, sometimes to 3 boosters per year, depending on the causes of the iron deficiency, which might not be only from the heart failure, as Aiste is saying.
Very good. There is an interesting question from the audience, a little bit provocative, and maybe you, Antonio, could address this. Is it better to manage patients with heart failure for iron deficiency as a routine, even without check of serum iron level? What do you think?
I mean, I can see the point, and I can see that it would be attractive to have preemptive treatments. However, I think we must also take into account that overload of iron is dangerous, and it's dangerous for the heart. If we have too much iron in the body, the organs that it preferentially deposits in are the liver and the heart. And if it deposits in the heart, it can cause problems with cardiac rhythm and even aggravate cardiac failure. And so with such accessible tests such as ferritin and transferrin saturation, they're done on a blood test. They're available almost everywhere in the world, if not everywhere. I think it's really not justifiable to treat without screening. If the tests were difficult, then I could see the point, but it's so easy to test that I think screening and then treatment is the right way forward.
Yeah, I totally agree. I think actually it will be a little bit dangerous, because although it's a fact that there is a high prevalence, but again, the way that we should do proper and modern medicine, it should be, you know, our gestures and our management should be supported by the evidence and the clinical evidence that, and it's relatively easy, as you demonstrated, to show the presence of iron deficiency, and that will guide the type of treatment or management that we should provide to the individual patient. So I totally agree with you. And actually that brings to another question, which is following up and quite a little bit related, and maybe Ali, you can take this one. The question from the audience also, may I know how would we judge for hemosiderosis, as it is also common in congestive heart failure? And this links with that.
This continues to what Antonio was explaining. There is something very important. Once the heart failure patient receive IV iron, and if you check the serum ferritin, it increases tremendously. So it is really very important not to give it blindly, and especially that we're talking about simple, not expensive tests present everywhere. So heart hemosiderosis is really very important, but I see this a lot in our thalassemia patients who are overloaded with iron and have heart failure secondary to iron overload. So it is important to couple, as I said, not only serum ferritin with saturation, make sure that if the saturation is very high, then you would do a T2 star MRI of the heart and make sure that it is hemosiderosis of the heart, which is not very common in a regular heart failure patient. However, I see it a lot in my thalassemia major patients who are regularly transfused with blood and have this, that might lead to further heart failure and arrhythmias.
Absolutely. Well, let's go back to Aiste. And you've mentioned a little bit in your presentation some of the difficulties that you were facing during this period of the pandemic. And I would like to have a little bit more of your input, not only from your own experience, but being the leader of a patient association. How has it been difficult, and what sort of recommendations or what sort of activities or pressure, if you will, have you done as a member of a patient association, and what sort of attitude patient groups can have here to improve the way that patients have access to proper medication? So how have you been dealing with this very, of course, very unusual time and very uncertain times that we live with these pandemics? What, in your own experience, and also speaking as a leader of a patient group, are you dealing with this, and how can we improve that even in the current circumstances?
Thank you very much for the question. I can speak from my own experience as well, and I can speak from the patients from the organization that I hear quite often. During this time in pandemic, we all know, I mean, in Lithuania currently the situation is very intense, and the hospitals are they're not closed, but they do proceed with the planned surgeries and planned testing. But the access to the medics and to the cardiologists is quite limited. So I think it is quite well working now, working along together with the not only patients, but in collaboration along together with the medics and physicians, that currently we are proceeding with telemedicine, if I can say that. So we do have a calls quite often with the physicians in terms of following up with the symptoms, following up the medication, and issuing the prescriptions if needed. But the another problem which I would like to highlight is that the patients are scared to seek help. And I think this is not only in Lithuania, it's worldwide, because we are often said to stay home, to not go anywhere, to isolate ourselves, you know, and we can see that it results to worsening of the conditions, that the patients who are already in the first or second stage of heart failure, they've reached the hospital already in the end stage because they waited for so long to seek help. So it's a collaboration again along together with the patients and physicians, as well as patient organizations, because we want to, and we say it out loud for the patients: if you feel the symptoms, if you have a worsening of your condition, if you feel that something is wrong with your body, you need to seek help, and you need to call your team or just simply, you know, call the emergency and go to the hospital. They do their work. They are working like day to day. It's not like the hospitals are closed. And for it to help patients to, you know, to be brave and not to be scared of the coronavirus more than, you know, worsening their own chronic illness. So that probably would be my answer to your question.
Thank you. And what you just said is very relevant, and that's actually a message. And we are being watched by many people. And one of the messages that we as medical community are trying to convey to the population is that please don't be afraid to come to the hospital. Don't be afraid to call your doctor or call the emergency services if you have a problem. And it's really dramatic what we've seen, particularly in the first wave, that many people, they delayed their coming to the hospital with acute conditions. And basically what happened, and that explains a lot the excess on mortality that we are seeing all over the world, was this fear. And actually, one message that may be relevant for the people, probably the safest place to be now is in the hospital. Because basically we have separate pathways for COVID and non-COVID patients. Patients are all tested, and looking at the numbers from different institutions, and this is the same around the world, it is clear today that you're probably much safer of getting an infection if you are in a hospital environment than going shopping or going to some other places that may be easier to get infected. So I think this is a very important message, because what is also frustrating from a medical perspective, and as a cardiologist, it was very frustrating to see patients coming very late with acute myocardial infarction, for instance, at a stage that if they would have come at the right moment, they will be properly treated. And as we know today, we can treat these patients and they stay without any sequelae even. And then they came very late, some of them with very advanced stages of heart failure, and some with severe complications. And that should not happen. So that's one of the messages that I think it's important. Is only not only about iron deficiency, but as a whole, if you have a problem, please don't be afraid to come to the hospital, call your physician, call your health professional, and make sure that you are properly treated, because for many conditions, we do have treatment that can save your lives. And that's an overall message that I would like to also convey here. Now, there's a question here, which is both for you, Aiste, as a patient, and then also for one of my colleagues. What is the immediate impact on patients of intravenous iron treatment? So I'm sure that you had some IV iron treatment. If you can say your experience as a patient, and then I will ask maybe Antonio to give his comment as a physician. So Aiste, you go first.
Okay, so as I experienced that myself, and from the beginning, as I mentioned, I could feel the dizziness, the fatigue, the shortness of breath. So after the testing that we see that, the hemoglobin and ferritin levels are quite low. So then we proceed with the iron IV. And after that, so I get admitted, for example, for 1 day at the hospital. I get the iron IV, which takes about like 7 to 8 hours. And after that, I get tested again 1 week after, just to see if the iron IV had an impact. But I could see and feel the results couple of hours on the same day in the evening later of that day. And what I could feel is I feel more energetic. I could feel that my skin got the color, as you know, with the low hemoglobin and with iron deficiency, we normally have the pale color of the brittle nails and the hair. So I see straight away the restless leg syndrome going away, which really is bothering to me because I like to sleep, and when I can't sleep because of that, it really makes me frustrated and anxious, which again is not good for me as a patient, as a heart failure patient. So I could see that going within the couple of days, but the feel of having an energy and power of doing and feeling like more active and seeing the world like, in its true colors. I think that's the effect of iron IV, which I get personally. So maybe Professor Almeida can explain more about it.
Well, that's a great experience that you just a description that you're just giving us. But Antonio, do you want to add from a medical perspective?
Thank you, Fausto. I agree. This was a great description. I think I'll have to, when all this is over, fly you to Portugal to speak to my patients and describe why they should have IV iron and how that helps. Now, I think there are two things that happen when you have IV iron. Obviously, IV iron means that the iron is available to the body very quickly because it's given in the vein. We use a slightly different formulation from what you have. We use something called carboxymaltose iron, which can be given a little bit quicker. So our patients come in and they have iron over about 45 minutes to an hour. And there are two effects. The first effect is an immediate effect in which patients have iron into the metabolism. So this well-being that you feel in this energy is not because of recovery of anemia immediately, but it's because of all the enzymes in your body that need iron, such as the ones that give you restless leg syndrome, etc., are suddenly being replenished. And then over the next week or so with IV iron, the bone marrow, which is where the red blood cells are produced, are able to incorporate the iron and produce new red blood cells. So there is an immediate well-being that you describe very well. And then there's also more long-lasting well-being, which is the recovery of the anemia, which normally with IV iron starts to be seen, obviously, in about a week or two. But then over the next month, it really replenishes to full levels. And so this is why it seems to last a bit longer. But then, having said that, it is important to keep monitoring because, as we said at the beginning, iron deficiency heart failure patients do develop iron deficiency over time.
That's great. Ali, I know you want to add something, particularly specifically for heart failure.
Yes, sure. I just want to say that there are two formulations available for IV iron. One formulation is the short-acting, which is given over a prolonged period of time, few hours, and the other formulation, which is the one which is superior to heart failure and inflammatory disease, which is the carboxymaltose, what Antonio has alluded to, which is given over a short period of time, 30 to 45 minutes. So the stay in the hospital would be very short. The dose is very high, where you need to repeat this is why I said it can be repeated twice per year. So there is a major difference between these two formulations. And in heart failure, the superiority of carboxymaltose has been shown in all clinical trials, where there is an immediate response in 1 week to 2 weeks, and it is given over a very short period of time. So even cost effectiveness will be by far superior, not only clinically in this group of patients.
Well, thank you so much. And we're getting close to the end. We still have a couple of minutes. And actually, I would like to have each one of you in 2 minutes, just to give us your, let's say, your sum up, your closing remarks, and what you would like to highlight, particularly considering the call to action that we are raising with this webinar. Maybe Aiste, do you want to start? A couple of minutes, each one of you.
Yes, of course. So there are a couple of things that I would like to pass on to the patients which are on this call today, is that know your symptoms, track your symptoms, and don't be scared to just explain to your physicians how you feel and what's the impact of the symptoms that you have in terms of the heart failure and iron deficiency. And another point I would like to highlight as well, during, again, that as we spoke already about the COVID and, I get admitted to the hospital and going for checkups. So please, if you feel any symptoms that it shouldn't be like that, you should definitely try just to seek help, contact your physician, contact your emergency or hospital, so you can get help as quick as possible. And as well, I would like to say that, again, which I mentioned when I spoke about my story, is that the patient organizations are there in your country. And if you need some help, or, we would like to collaborate and to make a greater things together in terms of like iron deficiency awareness and management of it, that we are willing to collaborate, because we do have the experience and we do have knowledge from the patient perspective.
Thank you so much, Aiste. Antonio, do you want to close with a couple of minutes of reflections?
Thank you, Fausto. I think the first thing I would like to reinforce is what Aiste just said. Patients' treatment is a collaborative action between patients and doctors. So please do refer to your doctor when you have new symptoms. Do tell your doctor when things are not quite the same. And be aware that iron deficiency can worsen the symptoms that you have. I think the other important message is really to doctors, to don't forget that because a patient has one illness, they can have other problems related or not to that illness. And so we need to really investigate and be aware of these other problems. And finally, I just really want to congratulate the World Heart Federation and patient associations for this great initiative. And I think bringing us closer together in this sort of forum is a huge advancement for medicine and for treating patients. Thank you.
Thank you so much, Antonio. Ali, please.
Just want to stress again on the importance of patients' advocacy in any disease, especially in chronic diseases, and this is very clear. I also would like to call for all cardiologists, and especially those that take care of heart failure, so that we can collaborate as hematologists, cardiologists together. At the end, I want to say that this is an inflammatory disease, and not only serum ferritin should be taken, because we are missing a lot of iron deficiency patients by using just serum ferritin. This is a really very important message, and thank you for including me in this meeting with you. And hopefully next year, we will, on the 26th of November, 2021, we can be face-to-face together. Thank you.
Well, thank you so much. I think this is one of the roles of awareness days is exactly to promote discussion among experts, but also among everybody regarding some specific topics that many times they are a little bit neglected or unknown even from the medical community. So today, we are basically celebrating this day to improve awareness on iron deficiency, which is a very significant problem, as we've seen from the discussion today. And it really gains when we have these discussions among experts from different fields and also including patient organizations. I think that's the main purpose of this type of sessions, is exactly to listen to the different areas, different components, and to have this perspective of multidisciplinarity, which certainly improves the way that we can not only practice medicine, but I would say above all, to improve management of any condition, in this case of iron deficiency and heart failure, which was our focus today. And we certainly gain when we have these exchanges between different experts from different fields, and also having the participation of patients. So on behalf of the World Heart Federation, I want to thank our panelists. I want to thank the European Hematology Association for sharing the floor with us today, and our two esteemed colleagues to be with us. I really want to thank Aiste Staraite from Lithuania, who came here as a patient, but also as a leader of a patient organization. And that, I think, was really important for this discussion. And finally, I want to thank our sponsor, V4 Pharma, that made this possible, this webinar and this discussion. So on behalf of all of us, and particularly to you, the audience that stayed with us for this last hour, I really want to thank you, and continue to do your job, continue to do your best, so we can improve the way that we can practice medicine, that we can basically, either as a physician, a scientist, or just as a person, as a citizen, to be able to have a better life, particularly in difficult moments like the ones that we are all facing around the world. So thank you so much, and have a good day. Bye-bye. Thank you.